Hi everybody, sorry for that slight delay. Thank you for joining the Fertility Circle event. We are joined by Jonathan Ramsay today, who will be speaking on male fertility. We're hugely privileged to have him with us today. He brings over 30 years experience and specialises in male fertility investigation and treatment, and he works closely with men of all ages, particularly supporting their health and well-being on their fertility journey. And he believes human fertility encompasses biology, emotion and psychology, and that it's really important to address all of those areas. And we're really looking forward to hearing more from Jonathan in all aspects of that today. A little bit of housekeeping. Please do, if you're not speaking, keep yourselves on mute, just so there's no background noise, although we absolutely welcome questions and we hope this will be a very interactive hour that we have with Jonathan. So please, you're welcome to either post in the chat channel, where I will be moderating any questions that come up, and we'll certainly have plenty of time for you to unmute yourselves, turn on your video if you wish, and pose your questions to Jonathan directly. So I have some questions from our community ready to go, but first off, I'm going to invite Jonathan to give a little bit more about his background and what he brings, and start off the conversation, if you will, Jonathan. Thank you.
Well, thank you for that very nice introduction. It's even more than 30 years that I've been obsessed with sperm. So that has the benefit, I suppose, of experience, but then on the other hand, due to, therefore, my great age, I'll be lucky to survive the next hour, so we better make it quick. So I think, where does it all start? Well, it starts with the simple observation when I first became a urologist that we might be missing 50% of the problem. When I learned about male fertility, then it was said that maybe 30% of a couple's subfertility may have a male basis. And I remember thinking to myself as a youth, that seems a little bit odd. This surely is a 50-50 situation. And then, of course, when IVF started in the 80s, I was training then, and therefore this gave us a great opportunity before IVF to look for possible causes of fertility, because if there wasn't any IVF, then you had no option but to try to treat the males. And therefore things like varicocele correction, looking for infections, was quite commonplace before IVF. And then when IVF started, this was a great solution to couples with male factor infertility who previously, of course, couldn't conceive at all. But then what happened was that when ICSI started, so injecting single sperm, it became written, or it became accepted, that ICSI was a treatment for male fertility, which of course it isn't. It may, and very fortunately, be a solution, but it's not really a treatment. And I remember thinking to myself, it is odd, we're now in the 90s, it's odd that so much investigation is lavished upon the female partner, perhaps not surprisingly because gynecologists are running the treatment. It is surprising that so much attention is given to the female. Of course, we need to know that the tubes are patent and that the womb is okay. But to a certain extent, those eggs and the quality of the eggs are fixed because they're fixed in time. And I remember thinking to myself, this is surely a bit odd because most men are making, in the time of our consultation, since I started talking, most men have made 10,000 sperm or so. And surely we must be able to do something to improve this, at least to understand it, because the male side of fertility is at least a dynamic biological situation. Well, now fast forward to the last 10 years, and it has become evident that this feeling, this intuition that you may be able to do something about sperm production in terms of treatment is beginning to come of age. And it's largely coming of age because we have more sensitive tests of male fertility, DNA fragmentation. We are looking more closely, once again, at the role of heating and varicocele, and we're looking more closely at the possible range, the possible effect of a range of organisms, bacteria, many of which are completely harmless, but just might have an effect on male fertility. So because of advanced testing, the field for treatment, as opposed to merely finding a solution, has opened up. So that's a bit of an introduction. So what have I done? Well, for the last 10 years, I've concentrated exclusively on male fertility, both its investigation and its treatment, and have worked very closely with gynecological colleagues, with nutritionists, and with scientists, not only to try to improve the lot of the men, but also to develop some strategies for trying to take on the more difficult cases. That's probably enough, and I'm ready for questions.
Wonderful. We've got some background noise there. Can you hear me okay?
I can hear you fine.
I'm having a bit of trouble with one of my computers, so I had to log into a second one simultaneously. So I'm switching between sound and video. Forgive me. So yeah, you mentioned the focus on women there initially when people are looking into infertility. Do you think, what are the typical treatments for male factor infertility, and what tests should people be getting for male infertility beyond the standard sperm test?
Well, the first thing is to talk about sperm tests, because sperm tests actually cause a great deal of misery and solve very few problems. That is partially, of course, because being a biological system, sperm production is very variable and erratic, and may also be affected by many quite simple things. Getting exhausted, getting overheated, having flu, even having a touch of COVID, even a touch of asymptomatic COVID. Taking things which many people would think don't really make any difference. How could possibly creatine and the protein shakes that you get in gyms, how could these make a difference? People think. And then they look around at their friends and they see the chap who's a bit overweight and manages to lose 5 or 6 pints of beer on a Friday night, and there's the odd cigarette, and there he is with 4 kids. So they think, how can these things have such a profound difference? Well, of course, it is biological, and depending upon who you are and where you started, all of these things can have a great difference. So a semen analysis is firstly unreliable, and secondly, it may cause undue concern. And the area of semen analysis that causes most concern is sperm morphology, because as all of you who've had sperm tests will know, the normal, in inverted commas, is anything over 4% of an ejaculate looking normal. Now, 4% of millions is really not much, so that straight away tells you that nature overproduces. These are huge factories producing lorry loads of product, and to have a normal count of only 4%, well, what that means is that there's not much difference really between 3% of a big number and 4% of a much smaller number. But of course, when a man and his partner sees abnormal morphology, they think, this is ghastly. This means that, firstly, I'm not going to be able to have children. And secondly, it occurs to them that if I do, perhaps the children will be abnormal. So sperm morphology, which is so variable, which is of itself a subjective measurement because it relies upon somebody actually looking at the sperm and counting them, this causes a great deal of trouble. So we're off to a bad start when a man may have plenty of sperm and plenty of motile sperm, but 3 or 2% morphology, because the seed of doubt is sown that he may be the problem, that this is a problem. And actually, it might not be at all, because the whole of the semen analysis, and indeed the couple's history, has to be looked at in context. So semen analysis can get us off to the wrong start. And once we're off to the wrong start, what happens is that the couple doubt that they can do it naturally, when in fact the semen analysis may in fact be normal. Then they go to the fertility unit, and a doctor, meaning to help, will point at the morphology of 2% and say, oh, well, you need IVF or ICSI. And once that has been said, then the couple, the view that they are not going to have a baby naturally is reinforced. And then, of course, they have IVF, and it's more likely not to work the first time than to work. And by the time that's happened, then they're absolutely sure they're not going to have a baby and give up all attempts at natural intercourse. So one has to be very careful in interpreting a semen analysis. It's a little bit like the difference between, if you have a sore knee or a swollen knee, having an X-ray and an MRI scan. Because of course the X-ray will only show you if you've got a broken bone. And the X-ray looks normal, but then the chap says, but I still can't walk, so what's the matter? Well, when you have the MRI scan, this of course shows that one of the ligaments is torn. So a semen analysis is only a superficial snapshot of fertility at that moment. And in order to be quite sure, for example, that a semen analysis really is abnormal, then one needs 2 or 3 of those tests so that those results may be consistently either subnormal or indeed consistently absolutely normal. So my message about semen analysis is that although at the absolute extremes, where there are no sperm or virtually none, or at the other extreme, when by everybody's opinion, this is plumb normal, in the middle, this may not be very helpful at all.
That's really thorough. Thank you for explaining that. We've had a lot of questions come in already. They jump about a little bit, but I might just dive in. Someone is asking, do you think DNA fragmentation testing should be offered to more men before they undergo fertility treatment? And someone else followed up with, what is DNA fragmentation test first? Perhaps you could speak on that a little.
Okay, so you were probably both listening to my analogy of the X-ray of the knee joint compared with the MRI scan of the knee joint. And a DNA fragmentation test is a little bit analogous to that, because one is looking more deeply into the sperm. One is looking at the payload of the sperm. And so in order to get a natural pregnancy, one needs enough sperm vehicles. So that's the sperm with its head and its tail. But then one needs a quality product, that is the DNA, in the sperm head. So to use another analogy, and I don't mean to be fatuous, if you were thinking of some lorries taking some product up the motorway, you couldn't really tell what was in them and whether the product was good by just looking at the outside. Now, you might think, well, that's rather a smart looking Eddie Stobart lorry. I bet that's got a valuable cargo. But you wouldn't know unless you looked in. And it's a little bit like that with DNA fragmentation, because this is looking at the quality of the DNA, which after all is going to form half of the embryo. It's looking at the quality of the DNA inside the sperm.
And is DNA, sorry to interrupt, fragmentation age related? A second follow-up.
Yes, it is. It is. So we, of course, wouldn't usually look at a sperm donor over the age of, let's say, 45. You know, interestingly, not dissimilar from female ages where fertility really alters. Why should this be biologically much different? And so, yes, the DNA quality of the sperm does deteriorate with age, but so too does the DNA quality of all parts of our body. Our skin becomes rather aged, and this is a DNA phenomenon, and this is happening everywhere. So it shouldn't come as any surprise that the quality of our DNA might deteriorate with age. And of course, it deteriorates much more quickly, just like our skin, if we haven't looked after ourselves.
Thank you, that's great. And again, new topic, but someone has been told they have a non-obstructive azoospermia. What are the options for someone facing that?
Okay, so non-obstructive azoospermia, once again, it's a little bit like the sperm morphology story, but worse, because azoospermia is a terrible diagnosis for a man. And my lot, the doctors, I think, are rather careless of giving that news, of handling that conversation, because it means, without proper explanation to most couples, that they are not going to have a baby. Of course, that's not entirely true, because in non-obstructive azoospermia, in somewhere between 40 and 50% of men, we are still able to find some sperm. So it's not quite as bad as it might seem. But I think one of the troubles with this diagnosis and the way that doctors handle it is because the ability to take the matter further and to look into it more closely, and indeed to try to retrieve sperm from inside the testicles, that ability and the resources necessary to do it are not universal across the UK. And so in some parts of the country, then a diagnosis of azoospermia is a very difficult one to take forward, because the local medical community is not used to being able to provide the treatment. And so if a general practitioner's experience in one part of the country is that the last 3 men who had this condition all had to use donor sperm, then that is genuinely what that doctor thinks, because in that particular region, nobody's taken it further forward. If you're in London, then there are 3 or 4 very advanced fertility units where non-obstructive azoospermia doesn't pose a huge problem, where urologists like me will counsel the patients and take matters further forward to look for sperm. So the importance, the gravity, and the impression of this diagnosis is very different for different people in different parts of the country. But generally speaking, we would seek, as with other parts of other branches of medicine and surgery, first to make a diagnosis, to try to understand why this has happened, to look at the genetics of the man, and to look at his hormone levels, and then to work out a strategy, because the most important thing when faced with this diagnosis, which is a really worrying one and people feel that they're nowhere, the most important thing is to make a plan, because once we've got a plan, at least we're moving forward, and we have a significant chance of finding some sperm.
Thank you. And what does oligospermia mean, and how can you treat it? Another question. Okay.
So oligo, the first bit of the word, is the same bit as in oligarch, meaning few. But these sperm might not actually be like oligarchs. They might be a little bit slow. So oligospermia is when there are few sperm. Oligoasthenospermia, like asthenic, is when they are slow. And then oligoasthenoteratospermia is when there are few, they don't swim well, and they don't look too good. So oligospermia is common. And the first thing, I think, is to go back to what I was saying earlier and to wonder whether we don't need another couple of tests just to make sure that something hadn't happened in the last few months to reduce the sperm count. Another very simple cause of oligospermia is that not all the ejaculate went into the little cup, because the best sperm and the densest part of the ejaculate is the first bit. And it's a ghastly business producing specimens in some of those ghastly little rooms that some of the audience will remember with loathing. So it's not an easy business, it's not a natural business, and not all of it might have gone in the right place. So lots of reasons for oligospermia, absolutely not necessarily a showstopper. And going back to another comment, is that whenever the semen analysis is abnormal in the presence of a longish time without a natural conception, then I believe that DNA fragmentation tests are useful.
Thank you. It's quite complicated terminology to navigate and just daunting journeys for everyone. Other questions? By how much can the sperm improve if a varicocele is treated? What would the success rates be in improving sperm morphology?
Okay, so the answer is significant. So treating varicoceles in oligospermia, in asthenospermia, where there's low motility, where there may be poor morphology, but most importantly, where those things are associated with poor DNA quality of the sperm, so that is high DNA fragmentation, treating varicoceles can produce very significant improvements. Not surprisingly, the effect of treating the varicocele depends upon how big the varicocele is and how much the sperm is being damaged by the heating effect of the varicocele. So the varicocele, which is a bunch of veins, usually around the left testicle, comes in different sizes. And one can actually measure the veins using ultrasound. And we know that when those veins are greater than 3 millimeters in diameter, then the heating effect of the varicocele is sufficient to cause sperm damage. But the other feature, important feature of a varicocele, is that when the man stands up, there is reverse flow of blood, because all blood in the veins, whether they be in the legs or the feet or the arms, blood in veins travels back to the heart. And that should be happening slowly all the time. But in a varicocele, the reason that it distends when the man stands up is because the blood flows backwards, downwards, from the hot part of his body in his tummy into the scrotum. And of course, biologically, the fact that the scrotum is worn the testicles are worn inconveniently in the scrotum means that they enjoy 3 degrees centigrade below core temperature. And if we think of getting into a bath that is 3 degrees below core temperature, that would feel pretty cool. So the testicles like to be cool, and everything we do in modern life draws them into our body. And if in addition, they've got a thermos flask of hot blood in wide veins around them, then of course the heating effect is quite significant. So if you want to measure the effect of treating a varicocele, first you must measure the size of the veins. Second, you must measure the blood flowing in this reverse way back into the scrotum when the man stands up. And then thirdly, you can get another fix on a varicocele by looking at the DNA fragmentation. So in other countries, particularly if you look at the guidelines for varicocele treatment in North America, then the guideline says that you always treat a varicocele when the veins are bigger than 3 millimeters, when the blood is flowing in the wrong direction, and when there's an abnormal DNA fragmentation test. And if those criteria are established, then you can get 50% improvement in all features of a semen analysis, including the DNA fragmentation. But it does depend where you start. But our message is nearly always treat a varicocele.
Okay, that's good news. Good to hear. Thank you very much. More questions. We're a busy evening. What I can do is ask a couple more generalized ones, and then perhaps give some time to the audience that have more personalized specifics, if you're happy to address those. But just lastly from me, and I've got others if no questions are forthcoming, but does zero sperm motility mean that IVF would be unsuccessful, and what are the options available?
Okay, so it doesn't necessarily mean that IVF, well, ICSI, so injecting the sperm, would be unsuccessful. However, it is not a good start, and most fertility units are unwilling to inject immotile sperm into eggs. And the reason for that, of course, is because the success rates are very low. And so, having said that, there are ways in which one might be able to test immotile sperm to see if they are living and injectable. But even so, in most fertility units, this is a bar to taking ART, that's assisted reproductive technology, that's in this case ICSI, or injecting the sperm. Immotile sperm are a bar to moving the matter forward.
Okay, great, thank you. We've just got more questions coming in, so we may as well pose them. What's the difference between the Comet test or the other type of DNA test beginning with an S? I can't remember what it's called.
So there are actually 5 different methods of looking at DNA and sperm. The 2 in the UK are the Comet test and the SCSA. Now, these are looking at slightly different aspects of the same thing. And the same thing is sperm quality. And the reason for doing either test is to predict either whether the man is naturally fertile or which kind of IVF, ICSI, IMSI, HIMSI, PICSI, all those acronyms, which kind of intervention might be best. Now, if we look at the Comet and the SCSA, then the numbers, the cutoff, will be different in each test. And this is largely because the tests are measuring a different number. So in the Comet records the average DNA fragmentation, and the SCSA records an index, that is a comparison between the good, the best, and the worst sperm. So straight away we have a numeric difference, which is based on the way in which the quality of the sperm is being reported. Each are useful, but you have to get used to both in order to be able to compare one with the other, because they are different. So in general terms, the Comet will generally read worse, that is higher, than the SCSA. So the SCSA numbers, if you compare them, look more optimistic than the Comet numbers. Now that doesn't mean to say that either is invalid, they are merely different, and one must compare like with like and not one with the other.
And is it worth redoing the Comet test after 1 year taking Impril or any other antioxidant supplements?
Yes, I think it is, knowledge is power. In this field where people will resort to comments like, it's just a numbers game, just have another cycle, there are plenty of sperm, we can get more eggs, just do it again. That, I think, is a very unstable position for people to be in. And without the knowledge that comes from advanced testing, and then the knowledge that whatever action one has taken has made a difference, or not made a difference, then I think it is an unstable proposition just to do it again. Because if you just do it again without changing something, the same result, of course, is likely.
And in terms of changing something, sorry, would you recommend other supplements beyond imperial sperm quality?
This, Jo, is a huge subject. So, and it's not right for me sitting here to endorse a bunch of supplements. What I will say, though, is that you do have to be careful with supplements, because on the basis that one of something you like is good, then two must be better. People do fall into the trap of taking multiple supplements. And of course, if you do that, then you may be taking too much of a substance or a vitamin that is in both your supplements. So you may actually be taking too much vitamin C, too much vitamin E. So one does have to be careful. My general comment about supplements, particularly antioxidants, is that they are good, not bad, because the usual cause of poor DNA quality of sperm is oxidative stress. Now, what I do in my practice is that I measure the oxidative stress when a man is taking supplements to see if he's taking too much, not enough, or just right. But just tipping in the supplements on its own is not good, but certainly in men who have high levels of oxidative stress, taking antioxidants is a good thing. But I leave the choice and the diet, because you can eat your way to better health. So I usually leave this particular discussion to nutritionists.
Well, that's interesting, because we've had a couple of questions around what can one do lifestyle-wise or nutrition-wise to improve male fertility. So perhaps we can connect those people with our expert nutritionists that are also on the Fertility Circle app. So feel free to go onto our message boards or ask the expert, or reach out to me and I can connect you. But if we park maybe those questions for now. Someone was asking, for fertility, would you recommend surgical repair or varicocele or embolism?
All right. Okay, so what this question is about is whether you deal with the veins, in other words, stop the hot blood from flowing back into the scrotum by tying the veins off. That's simple surgery. That's a knife and fork and a bit of string, or whether you block the veins off by inserting a coil in the inside of the vein so that it is blocked internally, because it's not the presence of the veins that matter, it's the blood flowing in them. Okay, so in order to decide which might be better, the first thing that most people do is to go to the literature to see if there's any evidence. Now, of course, evidence in the field of fertility is extremely difficult to find. In terms of real evidence, we are almost in an evidence-free zone. And the reason for this is that there are so many variables, because we're dealing with two people, we're dealing with two people of different ages, we're dealing with big varicoceles, small varicoceles, we're dealing with good surgeons, bad surgeons, good radiologists, because it's the radiologists who do the embolization, and those who've only done a few of these cases themselves. Now, if you compare good radiology, that is embolization, so a person, a radiologist who's done 300 or 400 of these varicocele embolizations, with a surgeon who has done 300 or 400 microscopic ligations of the varicocele, so that's surgical. If you compare those two groups, then there's not much in it. I have a preference for embolization, having most of my surgical life operated on varicoceles. But when you meet a really good radiologist or a really good radiological department, you might come to the opinion, as I have, that this is equally as successful as high quality surgery, but may have a few fewer simple complications because, of course, if you don't have an incision, then you can't get an infection. You can't get a hematoma, which is a blood clot under the wound. So my view is for embolization, but there's not much between high quality operation and high quality interventional radiology, which is embolization, in terms of the outcome if you're comparing like with like.
Very thorough, thank you. More questions. In terms of micro-Ts, someone's saying they've been offered locally. Would you recommend going to a specialist unit? And also, we have noticed some urologists use clomiphene to increase chances. Is this something you would do with someone who has non-obstructive azoospermia with normal blood tests and genetics?
Okay, so the issue of using drugs, usually anti-estrogen drugs like Clomid, in my practice does depend upon the pre-existing, the pre-surgical hormone levels. There is some evidence, and I've already said that we are largely in an evidence-free zone. There is some evidence, for example, that raising testosterone levels in men who have low testosterone levels, particularly in those who might have a genetic disorder, is actually quite effective in increasing the sperm retrieval rates. Extending that to all patients, however, may not be a sensible thing. And it may not be a sensible thing because some men, as individuals, feel pretty awful on these drugs. Clomid, tamoxifen, anastrozole, they don't feel well. And so it's not a very good plan to make a man feel a bit weak, maybe loss of libido and things like that, when one is not sure that it's going to increase the outcome. So once again, if ever there was an area where it is difficult to prove a benefit, it is this one. But I do have my own practice. I have a tendency to use drugs in particular conditions related to the levels of FSH, LH, and testosterone. So I tend to do it, but not always.
Thank you. And in your opinion, what is the best form of ART treatment when the male has higher levels of damage from the Comet test, up at 45%?
Okay, well, I would always say if you've got a high Comet and DNA damage, that we must try to find out a reason and try to treat this before we move to any form of ART. I think there is, again, some gathering evidence that if you can't get the DNA fragmentation down, if that is its best, then you are better off with some form of sperm selection, certainly ICSI, and possibly something further than ICSI, something like IMSI. So the message is, if your DNA fragmentation is raised, even when your semen analysis is normal, then you should be thinking of the sperm selection forms of ART rather than straightforward IVF. But in general terms, I would hope that further investigation might reveal a cause for the high fragmentation, for example, the varicocele that we've just been talking about, and that treatment of this will improve the fragmentation, thus improving the success rate of ICSI, but also improving, if the sperm count is good, the chances of a natural conception.
A follow-up question on that one. He's asking, he was interested to know more about IMSI versus PICSI max. We are hoping that the varicocele embolization helps lower the levels.
Yes, well, I would hope that the second part of the question or the statement is true, and then a discussion about PICSI MAX, PIMSI, IMSI, and all the other acronyms becomes less relevant. The message about all of those laboratory processes, and we're getting into the small print here, is that they are an aid to sperm selection to try to select those sperm that have less DNA damage. But once again, if ever there was an evidence-free zone, it's this. And the reason for that is that one is looking at small percentage increases in live births. And therefore you need thousands of couples, aged matched and everything else matched. You have to match the men really for their weight. You have to match them for their age. You have to do the same with the ladies. So to get to a conclusion is almost impossible. Excuse me. Is almost impossible, but the message is all of those things are claimed to have a similar percentage uplift in success.
Got it, thank you.
Sorry for the...
No problem. So someone's asking, my husband has had surgery for varicocele already, but has low morphology, 1% still. Should we be seeing a urologist to check on the varicocele before considering ICSI?
So did I understand that the varicocele has already been treated? Or is it just there?
I don't know, I'm afraid. I only just have, let's see. Well,
the answer is the varicocele may be relevant, and therefore treatment may be relevant. But all of these questions have to be...
Been treated, she's saying, sorry.
Been treated.
Yeah.
So all of these things have to be seen in the context of each couple, because there will be lots of competing interests. There always are. So, for example, with the varicocele, one has to say to oneself now, is it in this couple's best interests to have an intervention and then to wait for that intervention to be effective? Because for it to be maximally effective, we really want 4 to 6 months after treatment to have elapsed.
3 years ago and still showing low morphology at 1%.
Sure. So if the question is, should it be checked to see if it's been effectively treated, the answer is probably yes. But what I was saying was that you've got to look at each couple in a bespoke way, because if I was seeing this couple, I'd be saying to myself, okay, so if we're going to reinvestigate and retreat this varicocele, then we have to be sure that we're going to get a benefit which is greater than the disbenefit of waiting another 6 months for another cycle of treatment. So there's no catch-all answer for this. You've got to consider the couple. If, for example, they're going to run out of time for an NHS treatment, then it may well be better just to get on and have a treatment rather than spend time waiting for a varicocele to be effective, varicocele treatment to be effective.
Okay, one last question, then I am going to leave the last 10 minutes. I might not have done people's questions justice in how I've posed them to you, so we'll invite people to unmute. But is there any evidence of natural conception with a 0% morphology, low motile sperm and low count? And I know you've spoken on there being not that much evidence in general on this topic, but and I don't know if that's too specific to answer, but yeah, is there any evidence of natural conception with 0% morphology, low motile sperm and low count?
Okay, so the answer is yes. Even counts of 1 or 2 million, when couples were followed up for 2 or 3 years, there are natural conceptions, and a surprisingly large number. It may only be 5%. This was a study done in Denmark where men with severe oligospermia were either chosen to have IVF or ICSI, or were chosen to have no treatment at all, and both groups were followed up for 2.5 years. Now, it's extremely difficult to do a survey like that because you need the statistical power. There were 1,100 couples in that survey. And of course, to get 1,100 couples who volunteer not to have IVF is quite a big deal. So that is the only study that shows the natural conception rates with severe oligoasthenospermia. But the answer is it's not zero. And of course, it's very much dependent upon the quality of the eggs.
Thank you. I do have more questions coming in. I am going to pause just to invite people to unmute if they wish. Feel free to turn on your videos, first come, first serve, popcorn style, to either follow up a question or ask your own question if you wish. We've got Holly, I think, unmuted.
Hi, yes. So we've had 3 cycles of IVF with ICSI, and unfortunately, they've all ended in miscarriages just before 12 weeks. My husband's got low morphology, 1 to 2%. So we paid for the Comet Test and that come back abnormal. So we've gone back to our IVF clinic and they're advising us to look into PGTA testing. Do you think that's the right route, or do you think we should just go on and see a urologist?
Okay, so this is, if I explain to you the basis of what they are saying, and then you'll see why they've said that. I think they're probably saying that because the miscarriages, and I'm really sympathetic to this because it's awful. It's bad enough having the IVF, but then with the miscarriages, that's horrid. And then there's a tendency for my lot, the doctors, to say, well, never mind, you nearly made it. But that is to miss the point entirely. It's dreadful. But the reason they've talked about PGTA testing, which is genetic testing of the embryos for the other people listening, is because the time at which you miscarried is getting towards an area where it may be more likely to be due to the sperm, to the egg, than the sperm. And so testing the embryos before you put them back might mean that it avoided miscarriages. Although it doesn't increase the chances of having a baby, it does avoid those dreadful miscarriage businesses. Because usually the sperm DNA fragmentation, when it is poor, is responsible for much earlier miscarriages. So that's the rationale for which they have suggested, let's go for the eggs rather than the sperm, which may be quite sensible. But once again, not knowing your particular situation, I can only answer that in general, but that's the general answer. To avoid the miscarriages, they're thinking we must avoid the ghastliness of this. And that is a good way to do it.
Thank you.
Thank you, Holly, for sharing. Is there anyone else that would like to pose a question? Please unmute.
Yes.
Yes, we have someone.
Hi. Okay, so with our situation, we, just like Holly as well, we went through 3 cycles and all failed, and they were all ICSI. We were told that we had, my husband's sperm was of, I think they said it was low quality. The whole thing was upsetting, so I never really quite got the exact term that they were referring to. So this is the first time we've actually heard about the Comet Test and the SCSA one. What's the best way for us to get started on that? We don't even know. How do you go about it? Because we've used up our NHS goes. What do we do? How do we look to see who's the best one to, which one is the best one to go for, and what clinic would take us on? How does that work? We're not too sure.
Okay, well, most clinics now do have the ability to do the Comet Test. The company that supplies the Comet Test, which is actually in Belfast, have associations with many fertility clinics. So your clinic will certainly have heard of the Comet Test and may well be able to organize it for you, because what it requires is for a laboratory to process the sperm and freeze it and then send it for the Comet Test. Now, there are some clinics who have a similar arrangement to do the SCSA test. And as I said earlier, I don't think it matters too much which one you have, as long as the person who's reading the result is familiar with what that result means. And you're also quite right, because implied in your question is that if these are early miscarriages, then it may well relate more to the sperm than to the eggs. So the first port of call is your own clinic. They might resist it and say, oh, no, it's not worth it. But you might then say, oh, please just send it off to Belfast. And if your clinic isn't equipped to do that, then I'm quite sure there will be one fairly close somewhere that will do that service for you.
Thank you.
Thanks. Anyone else? I have one remaining question and then we'll wrap up, but just the last chance for any of the participants to unmute.
Hi there, thanks for answering the question earlier, Mr. Ramsay. I was just wondering, I've just recently, 2 weeks ago, had my varicocele embolization, and I was wondering about going back to trying naturally after a period of recovery, and how long a couple might try that before moving on to an IMSI-ICSI route.
Well, it's a very good question, James, and thank you very much for coming on to the program. When I do these things, it's most unusual for me to be having a man-to-man conversation. So thanks for bringing your specific problem. So varicocele embolization will begin to be effective from about a month after you had it done, and will be maximally effective in terms of natural conception round about 6 months. So there's clearly a window there in which you might take the view that I'm better, I might not be at my best, and depending upon your circumstances, the age of your partner, and what your fertility clinic is offering you, you might say, well, let's give this 3 or 4 months, and if it hasn't happened, then let's do the ICSI or the IMSI, or even the IVF, round about 5 or 6 months, by which time we will have maximum benefit. The alternative, of course, is to say, well, actually, I don't think we want ICSI that soon. We don't perhaps need it that soon because of the age of my partner. So let's give it a really good whirl, because if it was a big varicocele, then I'm in with a good chance of natural conception. And I mentioned when I started that if you're as old as me, we used to treat varicoceles before there was IVF. And we knew that if we treated a big varicocele, then somewhere between 35 and 40% of the youngish partners, 35-ish, would actually have a natural pregnancy round about 6, 7, 8 months after the varicocele treatment. So there's a long, slow, non-interventional route, which, providing your partner is fairly youthful, may actually carry a similar chance of a live birth to having ICSI sooner. Now, that's a dangerous thing for me to say, because it immediately causes a dilemma. And I come back to what I was saying earlier, which is that every couple needs a bespoke, sensitive opinion based upon their situation. Because if you just give advice based upon egg quality or sperm quality, and you just stick to that little rut, then you may actually end up upsetting more people than you help.
Could I, sorry, it's kind of a follow-up. What would you call as youthful? My wife is 37, and ideally we'd love more than one child. And it seems like there's different matters of opinion in sort of what counts as youthful, really?
Sure. Well, so I'm really straying into gynecological territory. And this is a tremendously difficult question for me to answer because,
Sorry.
because I'm damned if I do and damned if I don't, really. So if I were sitting with the two of you, then the decision here, in fact, is about whether you, as a couple, can wait. In fact, it's a much more human thing than a statistic, because we all know how awful it is every month when we were hoping that the period wouldn't come. And so the danger, the misery of not having IVF is not having IVF because you're not doing anything. And the way in which couples can tolerate that is very different between couples. People are either fundamentally interventionalist by nature, both doctors and patients, or actually they don't really want intervention. So how you play this at 37, and I knew you were going to say she was 37, because it's in that hinterland, how you play that has got a lot to do with your previous experiences and how you both emotionally can tolerate this. You see, one of the things you can do is to say, right, okay, we've got to move this along. We know the varicocele is going to make a difference. We know that the maximum difference is going to be 6, 7, 8 months from now. We can't quite tolerate not moving it on. So what we'll actually do is we'll wait for 3 or 4 months, and we're going to do IVF ICSI anyway then, in the full knowledge that things are going to go on getting better, and we may be, going to have a natural conception the second time around. So there are many compromises here, and I don't think that there is an absolute right answer based on numbers.
Well, thank you for such a human answer back. Thank you very much.
Thank you, James, for joining us. Very brave. So we have 3 more questions. I'm conscious of time, Jonathan. I'd just like to check in with you. It's 4 minutes past the hour. Do you have to?
I'll do 3 quick answers, Jack.
3 quick questions. Okay. The first one was, what is sperm aneuploidy and when would you test for this?
That's a very long answer. So sperm aneuploidy is relatively rare, and it means that a higher proportion than would be normal of the sperm are carrying wrongly arranged chromosomes. Now, this is I will just explain the concept, and then one might understand when it may be useful. So if you're dealing with any factory, let's say I am purchasing washing machines from a huge factory, and I would go to the factory, and in this case, the factory is the testicle, which produces millions of sperm, overproduces, and I would say, if I'm going to buy these washing machines from you, I want a certain tolerance for normal product. And I might set that tolerance at 5%. I might set it at 1%. And so too it is with sperm, that when the chromosomes develop within the sperm, that they have to be properly organized so that they are not mismatches. Now, aneuploid means that there are too many or too few. And if in a batch of sperm production, just like the washing machines, you exceed the tolerance limit for poor quality product, that is sperm that have chromosomes that are too many or too few, then the problem with that is that, like any other factory where there is the tolerance for broken product coming off the product line has been exceeded, that might mean that there are other imperceptible defects in all of the product, or much more of the product. An aneuploidy, therefore, excess aneuploidy in sperm, is a sign that spermatogenesis, the process of making sperm, is faulty. Now, I would do this when there have been miscarriages, when the DNA fragmentation is normal, when it seems that we are dealing with young, good quality eggs, and we're not really finding any other reason for this particular difficulty. You might also do it when there is a history of chromosomal abnormality, where the man might have some chromosomal abnormality in which the hard disk, which is driving the normality of all of his cells, including his sperm, is having the information mistranscribed. There's a transcription error somewhere. So I don't do sperm aneuploidy very often, but when you do it, and if it is abnormal, it is of great significance.
Very clear. Thank you for simplifying quite a complex issue. Is there much that can be done for erectile dysfunction when medication is required in order to make sex possible?
Oh, it is unusual for medication to be ineffective. Unusual. I think that one of the commonest things I see with regard to erectile dysfunction is part of a whole spectrum of performance anxiety. And the longer it goes on and the more of a task the whole business of trying to conceive becomes, then this enhances the performance anxiety and also means that erections don't stay for so long. It's a biological phenomenon. If you think about this in the animal kingdom, animals are most vulnerable when they are mating, and that's why they generally mate in the day, not in the middle of the night. And they are alert to anxiety. So if something happens that provokes anxiety, then they lose their erection so they can disengage and run off into the undergrowth. And of course, the underlying anxiety about the fact that this act of trying to create a baby, this act of ejaculating, has been so unsuccessful, and the anxiety provoked by the fact that it's got to be now as opposed to tomorrow, it is not surprising that this is quite a problem. And the way I manage it is to give a low dose of one of the drugs, the newer drugs, that is very effective, a lower dose every day, so that we don't have to premeditate this. Because the trouble with the drugs like Viagra is that you add another cause of anxiety by saying, and if you're going to have sex because we must have a baby, you've got to take this, and you've got to take it, 63 minutes before the act. And that just makes it worse. Because now if it doesn't work and you've had a bucket load of Viagra, the end is nigh. In fact, it's just because the whole thing has caused so much disquiet.
I can imagine that's, very stressful times for everybody. Thank you. So the last question was just to reflect how much lovely feedback we've had on the chat channel, saying how not only thorough but also simplified and clear you've been, and comforting to be able to ask these questions as well. So thank you so much, Jonathan. Your expertise is unrivaled, clearly. And on that matter, people are asking, how can they connect with you? I expect you have wait lists. What do you charge was a question, and how can people reach out to you for further support?
Well, I'm here, and the website has got all the details on it. And we do try to be transparent about what it costs. And of course, seeing people and trying to help them on their journey is costly because it takes a lot of time. I don't know whether people can see the size of this room, but this volume in W1 is sort of expensive place to be. But I do try not to be too expensive.
Okay, I've put your jonathanramsay.co.uk website in the chat channel. Is there any, and of course, everyone can go to the Fertility Circle. Jonathan's listed as one of our resident experts under our clinical pod. So you'll see his bio, contact details, any social media handles, and links that will take you directly to be able to access him in that way. Is there anything, any other routes you wanted to point out, Jonathan?
Well, do you know something, Joe? I wouldn't know them even if they were there. I can only do this with my helper Naomi, as it is. So I am pretty techno incompetent, and I never read my own website.
Wonderful. Well, we've had the pleasure of your expertise here today, and I think you've answered a lot of questions, and we've just got thank yous pouring in. So really well attended and delightful to have that level of expertise. So do go onto the Fertility Circle app. We do have lots of information in our Learn section where you can find out a bit more about male fertility. We're producing a male fertility fact sheet. Any questions, reach out to hello@thefertilitycircle.com and we'll try to direct those. And there's also an Ask the Expert section on the app, but do go into the app and reach out if we can be of any further support. Jonathan, thank you so much, so thorough. Thanks to all our attendees. Really appreciated.